Good afternoon, good morning, good evening, wherever you're joining us from. Welcome to the latest Hear from the Experts webinar. This series is helping people better understand multiple sclerosis and highlight some MS-related resources. Plus, we are here to provide tools and tips to navigate your MS journey with more knowledge and confidence. Our intention is to help you learn more about the disease, treatments, research, wellness strategies, our programs at the MS Society, and much more. My name's Gabrielle Vito, and it's a real honor for me to be your moderator for today's session. I'm a longtime volunteer with the MS Society of Canada since my own diagnosis with multiple sclerosis way back in 1996. I have relapsing remitting MS with the onset of fatigue. I think these newly diagnosed seminars are some of the most important webinars we do, so I'm really happy to be here with you today. And I'm joining you from beautiful Vancouver Island in British Columbia. Now, before we get started with today's presentations, let's briefly go over a couple of housekeeping items. Your microphones have been muted and will remain muted for the entirety of today's broadcast. This session is being recorded and will be available soon on our website in English. We also do add French subtitles, but that version won't be available for several weeks. The recordings are always available on our website under Nationwide Webinars from the archive page, and they're also going to be on the YouTube channel. If you have a question for any of today's panelists, please type it into the chat box on the right-hand side of your screen, and we'll try to get to as many questions as possible following today's formal presentations, although we have received some pre-submitted questions as well to help get us started. Now, this session is also being broadcast on Facebook Live, and we welcome that audience as well to type any questions you have into the chat box. Now, please note that questions pertaining to specific personal situations likely cannot be answered in this type of a venue, and we recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for your specific questions. Now, speaking of the MS Knowledge Network, we have staff, including an MS Navigator, monitoring the chats today, and they will share appropriate information if it's needed. Now, also please note that the MS Society of Canada, as always, does not approve, endorse, or recommend any specific product, therapy, or service, but provides information to assist individuals in making their own health and wellness decisions. So today's broadcast is titled MS 101, Newly Diagnosed Panel Session. This is an opportunity to learn more about multiple sclerosis and what the MS Society of Canada does to support people affected by MS. We're very grateful to Roche Canada for providing sponsorship to make this broadcast possible. Our first panelist today is Jesse. He's recently diagnosed with MS and is here to share a bit about his MS journey so far. Welcome, Jesse. Please go ahead.
Thank you very much. Thank you for having me. Hi, everyone. I'm very excited to get to participate in today's event. I spoke here last year as well and thought that session was a success in helping more newly diagnosed people access information and resources. As mentioned, my name is Jesse, and I'm based in Toronto. I've been volunteering with the MS Society for over a year now, and I help run the support group for newly diagnosed people, a group that works to engage and connect the newly diagnosed in the MS community. Thank you so much for having me. I've been asked to share the story of my diagnosis, so similar to last year, I'll go from the start. In late 2019, I was not in a good place. I didn't realize it at the time, but I was full of anxiety. I drank and smoked an excessive amount. I was always tired and fatigued. At times, usually while in transit coming home from work, my legs would mysteriously feel like what I could only describe as jelly. I remember always asking myself, how will I walk home from the bus stop if my legs feel like this? It was bad enough that I often felt like I would fall flat on my face on the bus or subway. On top of this, one day of September that year, I noticed I began to trip on words or stutter in a meeting at work. I was concerned. I saw my family doctor. Immediately, he could see that I had experienced what he called a nervous breakdown. He provided anxiety medication. I found his diagnosis to be validating, like a feeling of, I'm not crazy. But I told him that something was wrong in my brain. I just knew something was off. I asked for an MRI. He paused and said, okay. I had the MRI in November and received a call back in December. I was asked to come and see the doctor again in January. January 5th was the first time I heard a doctor say MS. There was definitely an awkward moment where I had to ask, what's MS? I first saw a neurologist in February. That's when I first heard words like disease-modifying therapy, or DMT, clinically isolated syndrome, or CIS, disability, lumbar puncture, lesions. All these words were being used in relation to me. My MRI had shown lesions in my brain and spine, a couple dozen of them. We started talking about treatment. Feeling lost, I reached out to the MS Society and joined a support group. I knew I wanted to get involved with this new community I now belong to. In August, I had a lumbar puncture. My diagnosis, which up until this point was still CIS, was confirmed as a diagnosis of relapsing remitting MS. That was August 19th. It's funny how these dates stay with you. I began taking Copaxone, the DMT recommended to me, a few months later. That summer, I began to reflect on everything. Spent a lot of time going for walks and trying to make sense of it all. I came to some realizations. I realized that I don't have time. There's no time to feel sorry for myself. There's no time for fear. And there's no time to stress about the things that I can't control. The support group I had joined continued monthly. I met some amazing people who had experiences like me. I didn't know anyone with MS prior to my diagnosis. Through the support group, I learned about the stages of grieving. I learned about the concept of old me and new me. I learned I was grieving for the old me. That concept really resonated. Through a friend, I learned about a Canadian charity dedicated to MS education called Direct MS and a diet they developed called the Best Bet Diet. I adopted that diet, and my fatigue, which had been a daily presence in my life up until that point, slowly started to alleviate. My jelly legs disappeared. I realized there were some elements of my disease that I have some control over. Slowly, my mindset around all of this started to change. At this point, I connected with some organizers at the MS Society. They were very interested in starting a support group for people who were newly diagnosed with MS and felt I could help by facilitating the group. We got that up and running in September of 2021, and I continued to meet incredible, resilient people through that new group. We meet on the first Wednesday of every month. Some people in the group come to listen, some come to share, many come to ask questions. Everyone who joins us in these meetings is contributing to building a community of people who can relate, understand, and empathize. The connections we make in these meetings are without a doubt the most valuable aspect. Old me was full of anxiety. Old me would never spend time talking about himself to a group of strangers. Old me was also always hungover. I decided that new me is educated. New me wants to help others. New me is hopeful. There is silver lining here, I've realized. Now is the time to take stock of my life. Now is the time to reflect from my new and unique vantage point. This is something that is bigger than me. I've had a number of MRIs over the last 2 or so years. Some have shown disease activity. My MRI in November of last year showed what is called a stable burden of disease, no new lesions. I have to be hopeful. I don't smoke anymore. Drinking is under control. I make time every day to do the things I love, like reading books and playing music. In addition to my DMT, I live by my new diet. I exercise every day and go for lengthy walks as often as possible. These are the things I can control and will continue to control until I can't. Thank you all for your time. I hope my story can help to provide hope to today's participants, and I'm looking forward to answering any questions the group has later in the discussion too. Thank you.
Thank you so much, Jesse, for your share. It's so valuable to hear directly from people with MS. Now, our next panelist is Dr. Laura Schiffer. She is a neurologist and has been on staff at North York General Hospital in Toronto for more than 25 years. Thank you so much for being here, Dr. Schiffer. Welcome. Please go ahead.
Thanks very much for the welcome, and I hope you can all see and hear me okay. I think I'm going to need there they are. There's my slides. So I'm going to try to cover a lot of ground in a relatively short period of time. I may not get through all of my slides today, but hopefully we'll make some headway, and hopefully what I do get to cover will provide some information for those of you out there. So what is multiple sclerosis? Multiple sclerosis is one of the commonest neurologic conditions affecting the central nervous system, especially here in Canada, where it's a particularly common disease. The central nervous system being your brain, your spinal cord, and also, interestingly, your optic nerve. And we call this an inflammatory demyelinating disease. So what do those big words mean? Well, inflammation is something we probably all are a bit familiar with. If you've ever had a skin infection or a wound or a cut, you've seen how it gets kind of red and swollen and hot. And that's because your immune cells in your body immediately rush to that area. And inflammation can do positive things. It can help clear infection and it can help heal. But when inflammation is out of control and directed against one's own tissues, then it can be a damaging thing. In the case of MS, there is inflammation in the central nervous system, specifically directed at and affecting myelin. And myelin is a fatty material that is an insulation around nerve fibers. So nerve fibers have these long processes called axons. Axons are kind of like an electric wire. They are a conduit for electrical impulses to travel along so that one part of the nervous system can communicate with the next. And myelin insulates that nerve, that wire, so to speak, in the same way that a lamp cord has insulation around it. If you fray or injure that insulating material, then current leaks out and the electrical impulses do not get transmitted normally, and that produces a short circuit, if you like, and in turn symptoms. So in MS, we have inflammation affecting those linings around the nerves in the central nervous system. And this is quite a little image here that shows us what a nerve fiber with its insulating myelin around it looks like, and what happens when there is injury and scarring. And MS, literally translated, really means a disease of multiple scars. And we can see evidence of this scarring when we look at MRI scans. What causes MS? Short answer is we wish we knew. We don't know exactly what causes MS, but we do have quite a lot of information about some of the things that contribute to the development of MS. There is a genetic component to MS, but it isn't a sort of inheritance that's simple and straightforward like eye color or hair color. There are lots of different genes that probably are involved in predisposing people to multiple sclerosis. We do know that there is an increased incidence amongst first-degree relatives of people with MS. And in addition to that genetic predisposition, there is also environmental risk factors. And these include many things, comorbid conditions that people may also suffer from, and also exposure to things like viruses may have some influence in the development of MS. A couple of really important takeaway points is to know that MS is not catching. It's not something you can pass on in a contagious kind of way to someone else. And fortunately, life expectancy for the vast majority of MS patients will be roughly normal. These are a few things environmental-wise or comorbid condition-wise, if you like, that can help predispose or make a contribution to the development of MS. Vitamin D deficiency. And this may be one of the things that is, or one of the reasons why MS tends to be more common in northern climates. One of the reasons why here in Canada we have a very high incidence of MS. It may have something to do with low vitamin D levels. Vitamin D is a vitamin that can be created in the body with sun exposure, and when there's low UV exposure, we can suffer from low vitamin D. Obesity and smoking are another couple of things that can predispose people to MS and might worsen their course once they're diagnosed. So these are things to think about in terms of lifestyle modification. So the diagnostic process. I think it's really important to understand that there's no one test that can tell you if you have MS. So we don't have one blood test. We don't have even an MRI. That one test alone does not tell us whether someone has MS or they don't. Really, we have to combine someone presenting to us with a history, with a story that is suggestive of MS, together with a physical examination that may show abnormalities consistent with multiple sclerosis. And then there are tests, usually specifically an MRI scan, where we look for the lesions of MS. And we can see pictured here what a typical MS MRI can look like. And then there's also some ancillary tests that we don't always do, but that in certain specific circumstances are appropriate. And those include something called evoked potentials, which is a test where you put little sticky plasters on your scalp and watch the brain waves as certain sensory stimuli are submitted to the patient. And that is a measure of how those sensory pathways are functioning. And then there's also a lumbar puncture where we take spinal fluid and send it to the lab to analyze it, looking for a specific pattern of proteins called oligoclonal banding. But even that test, even when oligoclonal banding is present, that by itself doesn't make a diagnosis of MS. There are other neurologic conditions, for example, where people can have positive oligoclonal banding in their spinal fluid. So really, it's the constellation taken together that makes the diagnosis. And the other couple of points I would make is that to diagnose someone with MS, there's a couple of requirements that are often referred to as dissemination in time and dissemination in space. And this refers to the fact that to meet the clinical diagnostic criteria for MS, people have to have multiple areas of the nervous system involved, and they have to have involvement over time. So if someone presents with one new, straightforward episode of neurologic dysfunction, that doesn't necessarily meet the criteria at that time for a diagnosis of MS, even if it's quite suggestive, which is one of the frustrations, I think, for patients often when at the beginning there's some question mark or a little insecurity about what the diagnosis is. So sometimes it can take a while to firm up that diagnosis. So types of MS. So mention's already been made of clinically isolated syndrome. Jesse mentioned this. And that's exactly the person I was just describing, someone who presents for the first time with a new episode of neurologic difficulty. If they haven't yet had other episodes in the past, we may wind up calling this clinically isolated syndrome, but we know that there is a significant risk that people who present with clinically isolated syndrome will go on at some future time to meet the criteria for a diagnosis of MS. So for example, one of the common ways in which MS can present is with a bout of what's called optic neuritis. That is an inflammation in the nerve of the eye, and people will complain of a loss of vision or blurry vision or colors not looking as vivid in one of their eyes. If someone who presents with optic neuritis has an MRI scan at that time, if there are lesions in the brain suggesting or compatible with MS, they have a very high likelihood over the next 5, 10 to 15 years of going on to a diagnosis of MS. So something like 75% of people who present in that fashion with an abnormal brain MRI will, by the time 15 years has elapsed, they will satisfy that criteria for MS. And so in individuals like that, even though we call it clinically isolated syndrome, we nonetheless discuss treatment at that time. Relapsing remitting MS is by far and away the commonest form of multiple sclerosis. The vast majority of people who will receive a diagnosis of MS will be diagnosed with relapsing remitting multiple sclerosis. And these are individuals who have episodes of neurologic dysfunction. So we refer to those as attacks or relapses or exacerbations. And in these cases, symptoms appear, and then typically they will improve. And they may resolve completely. One of the challenges is they may not resolve completely. And so you can imagine that if people are having different symptoms over a length of time, and each time they run into problems, they are not resolving or recovering 100%, then over time there is an accumulation of a little bit of this, a little bit of that, and that leads to disability. And that is what we want to prevent when we offer treatment for MS. Secondary progressive MS is the sort of MS that a large number, probably the majority of people with relapsing remitting MS may go into eventually, particularly if they're not treated. So around 15% of people with relapsing remitting MS at some point in the next 10 to 20 years after their diagnosis will move into this other phase of the disease. And this is a situation where people may or may not still have episodes or relapses, but in between those, they're describing and developing kind of a general gradual worsening of symptoms or accumulation of symptoms. So this sort of progression without relapses. And we call this secondary progressive MS. We obviously want, when we are intervening with treatment, to kind of push this stage of disease off as long as we possibly can, possibly indefinitely. And then finally, there is primary progressive MS, and this is the least common form of multiple sclerosis. It is one in which people, from the very beginning of their disease, never really experience discrete relapses, but rather seem to have this slow, gradual accumulation of symptoms over time without episodes. For very many years, we did not have very good treatment for this form of MS. And fortunately now, for the first time in the last few years, we finally have treatment where we can intervene in this form of MS as well. Just a few words about what is a relapse. This can sometimes be a point of confusion. A relapse is an episode where you develop new neurologic symptoms or distinct worsening of symptoms you've already had before over a discrete period of time. So over a matter typically of some days to weeks, sometimes months, symptoms that were present before get a lot worse or new symptoms appear. And then they ease up. They may resolve completely. They may not resolve 100%. They may leave someone with ongoing symptoms afterwards. Just a few words about a pseudo-relapse. Exposure to heat, so extreme exercise where you get very overheated, being in an extremely warm environment or very hot weather, having an infection associated with a fever, for example, or other really stressful things like being involved in an accident or suffering trauma. These are things that can also cause people to experience a worsening of previously experienced MS symptoms. But this is usually a shorter-lived thing and is not considered to be a true relapse. So this is just kind of a laundry list, really, of a whole bunch of different symptoms that can occur in multiple sclerosis. And I think it's really valuable that this list has been divided into invisible versus visible. And I also think that it's the little snowflakes on the screen are important as well, because while no person, fortunately, with MS is likely to have all of these symptoms, each and every individual with MS is unique and is going to have their own constellation of symptoms that are distinctly theirs and are different and not the same as someone else. So every MS patient is different. They have a different combination of these symptoms, which means that treatment also needs to be tailored to the individual. It's also important, this division in visible versus visible. Because I think one of the challenges with living with MS for many patients is that they may not look sick. And I mean, in many ways, that's a good thing. But sometimes that's a hard thing because others can't understand that there are difficulties that that patient is facing, that there are symptoms that are limiting their ability to function in everyday life. And some of those symptoms can be invisible. And some of those symptoms, some of those invisible symptoms actually can wind up being the most debilitating symptoms for patients. So I'm just going to run this part of the talk. I'm going to run very quickly because I don't want to dwell in great detail on each and every symptom. We would be here for a good couple of days if we did. But I just want to talk about some of the really common things that MS patients do experience briefly, because I do want to get on to talk a little bit about treatment. One of the things that is really important to understand, though, when you look at a list like was just on the screen, and as we go over some of these symptoms now, is you may think to yourself, these are really common things. Lots of people have fatigue for a whole host of reasons. It doesn't have to be MS that's causing their fatigue. And this is true of many of the symptoms that I'm going to mention. Is they're not exclusive to MS. And so one of the things that can be a little bit of a problem is when people are worried about MS, they may resort to Dr. Google. And if you go on Dr. Google and you look at a list of symptoms, it's very easy for any one of us to talk ourselves into many diagnoses, not just the diagnosis of MS, but many different diagnoses. So just if you have all these symptoms, it doesn't necessarily mean you have MS. You might, but it's really important that people in whom a question of MS has arisen, in my view, and I think most neurologists' view, you really need a neurologist to diagnose you with MS, which I recognize is very challenging because access to neurology isn't always easy and straightforward. But it's a complicated disease and it isn't always straightforward to diagnose. And so really, at least the initial diagnosis needs to be made by someone who has experience in this condition. So fatigue. The kind of fatigue people with MS will describe is oftentimes a kind of fatigue that isn't alleviated by just taking a nap or sitting down and resting for a while, although it might be helped by those things. But it's really often described as a kind of hitting a wall kind of phenomenon where people suddenly they're all in. They need to take a break from activities. And fatigue at some point or other will be an experience for the vast majority of patients with multiple sclerosis. It can be aggravated by a bunch of other concomitant things like mood issues. Some medications that we use can have fatigue as a side effect. And if one has fallen into a habit of not being active, then lack of activity, lack of exercise can contribute to fatigue. Not having good sleep habits, for example, stress, anxiety, these are all things that can contribute to fatigue. So fatigue is something that can be managed. There are medications we use for fatigue in MS, but additionally, having a really healthy lifestyle with exercise of a moderate degree, punctuated by proper periods of rest, and so forth, can really help. Heat intolerance, we call this Uthoff's phenomenon. It is also very common. The classic description is the person who can get into the sauna or the hot tub or a hot bath on their own steam and suddenly finds that they can't get out because they've developed such profound weakness, and that is due to the heat. And so it is important for people with MS who have this, not everyone with MS experiences this, but for those that do, it's important, especially in the summer months, to be aware of that and to stay cool. So staying in air conditioning, cooling drinks, cool clothing, fans, taking breaks from the heat and the outdoors are necessary. Pain. Pain is unfortunately a common symptom in MS, and it can be of a variety of types. And depending on the type and the cause of the pain, there are different approaches and different treatments. So people can experience what we refer to as neuropathic pain, meaning that when sensory pathways in the central nervous system have been injured, people will have discomfort that is often described as burning or freezing, sometimes sort of lancinating or electric or numbing kind of pain. These are sort of different adjectives to, the pain from a musculoskeletal injury, which is more commonly aching, let's say. So neuropathic pain is very common and typically treated specifically with medications that are not conventional analgesic type medications. So things like Tylenols and Advils, they don't usually do the trick for neuropathic pain. We have a whole other group of medications that can be used for that. But people can have a variety of kinds of pain. So sometimes increased tone in the muscles. When the motor pathways are affected in the central nervous system, it's common to have what we call spasticity, and that's an increase in tone in the muscles. And that spastic or tight kind of muscles can have its own pain associated with it. And secondarily, if you do have spasticity or weakness, that can take a toll on the joints and so forth. And so people can actually have more conventional musculoskeletal type pain as well. Just a couple of words about the Lhermitte sign, very common. It's an experience when people flex their neck. They may experience an electric shocky sensation down the back of their neck, sometimes into their arms, shoulders, or upper back. That can be quite uncomfortable. And again, there are medicines we can use to deal with that. If someone hasn't had Lhermitte's before and is suddenly developing that may be due to a relapse. Allodynia refers to a kind of pain where things that normally wouldn't be painful to someone who was not affected with MS are experienced as painful to the patient with MS. So touching something hot or cold that would be experienced as heat or cold to someone who has an entirely normal nervous system can, for someone with MS, be perceived as extremely uncomfortable. Sensory dysfunction, so feelings of numbness, tingling, pins and needles, electric shocky type sensations. These are very common experiences for patients with multiple sclerosis, particularly this experience of sort of a band-like sensation around the middle. That's often part of MS. Cognitive changes. So cognitive changes are something which way back in the day, we didn't think was actually a consequence of MS. We didn't think it used to be taught many, many years ago that MS didn't affect cognition. And we now know that is not true. A very significant number of people with MS will have cognitive changes in association with their disease. The good news is that these are not usually of the degree or the type of cognitive difficulties of the severity that we would see in some other neurologic conditions, like, for example, Alzheimer's or dementia in general. These tend to be more subtle difficulties. So problems, for example, with concentration, particularly with speed of information processing, ability to switch quickly from one sort of task to another, being able to be very fluent in one's language, speak very quickly. These kinds of things can sometimes be issues in MS. So while they're subtle, unfortunately, it does not mean they cannot be debilitating. And unfortunately, sometimes cognitive changes are the main reason for people withdrawing from their work. I will also add that the kinds of cognitive problems that are frequent in MS are not usually well measured or well detected by some of the very commonly used short, quick neuropsych tests that we routinely do in the office. We have to pick some other special kinds of tests that really get at some of these more subtle neurologic difficulties if we're wanting to pick up or measure over time cognition in the context of MS. Mood issues. Mood issues are common. These can be part and parcel of the disease itself. They can also depression, etc., anxiety. These can be reactions to the diagnosis. And so often people with this condition do need some support from counselors, psychologists, or psychiatrists, as well as neurology. Other kinds of mental health issues like full-on panic attacks or bipolar affective disorder, obsessive compulsive disorder. These are all seen in the MS population as well. And so if people are struggling with mood, it's something that's important to bring to the attention of your clinician so that it can be addressed. Visual problems, I won't dwell on these. I've already made mention of optic neuritis, a very common condition in MS and a very common presenting symptom of MS. Double vision, seeing two of things, is also another not uncommon complaint. Bowel and bladder function can also be an issue, particularly in individuals who do have involvement of their spinal cord in their disease. And it's important, again, to report this if you are experiencing this, because sometimes we do need, for patients with MS, to have some urologic testing done. Certain kinds of bladder issues, if they're kind of left long-standingly unchecked, can secondarily damage the bladder muscle itself. And then that means there's a second reason to have bladder issues. So mild issues, we don't necessarily jump to urologic testing, but if they become more pronounced, we definitely do. Balance and coordination problems, very common. Falls. So anybody who has a diagnosis of MS, really, when they are planning, for example, an exercise routine, I always encourage patients to incorporate some kind of balance exercises in what they do. So things like Tai Chi, for example, is a form of exercise that really works balance and is great for preserving balance. Truth of the matter is balance problems are very common among all of us. As we age, our balance will become less secure. So all of us should really be doing some balance retraining exercises, if you like. But I think that's doubly important in anybody who has a chronic neurologic condition like MS, where balance can be affected more so. So now I want to go on to say a few words about disease management. Again, I think there was brief reference made by Jesse already to DMTs, or disease modifying therapy. In addition, we do also treat individual relapses some of the time. And then there are also, and I've made mention, as I've been speaking about different symptoms of MS, about specific treatments that we may use to target specific symptoms. So, for example, there are medications we use for pain. There are medications we use for fatigue. These are not things that will impact the underlying disease process. The disease-modifying therapies are really the thing that will do that. And so I'm really going to dwell on discussion of those now. But yes, symptomatic therapy is also part and parcel of the management of MS. And then there are also a variety of complementary and alternative therapies that many patients do also utilize. And I'll say a few words about that as well. Just a couple of words about relapse management with steroids. I think it's also important to know that not every single relapse necessarily needs to be treated, particularly with steroid medication. What steroid medication does is shorten a relapse, which, of course, if someone is really in a bad way with a relapse, it's quite valuable. However, steroids come with their own set of problems. And so we don't really want to be exposing people to the side effects of steroids for every single MS relapse. We really tend to keep them in reserve for significant relapses where people's function and ability to get to do their normal activities is being affected. In those cases, then it is important to try and intervene and do something to shorten that episode. But if somebody has a couple of days of increased or new numbness and tingling, for example, that's not necessarily going to be a relapse that we will treat. It's nonetheless a good idea, important for patients to take note of that. So they may not speak to their neurologist or their doctor every time they have that experience, but jotting that down and remembering to bring that up at your next appointment is valuable because the frequency with which people are having relapses has relevance for treatment. Just a few words about ongoing investigations before I delve a little bit more into treatment. What can you expect once you've been diagnosed with MS? What should management look like thereafter? So really, normally speaking, anybody with that diagnosis should be seeing their physician on an ongoing basis, at least a couple of times a year. And if somebody is very sick with their MS, if someone has very active MS, then they may be seeing their physician more often than that. And those appointments afford an opportunity to report symptoms and also for your clinician to examine you, because what we see on people's physical examination matters. And that goes into our sort of mental calculations on whether we're happy with the treatment we have a person on or whether we should be thinking about switching them. And then also, depending on which medications are being used, blood work may be needed over time, repeatedly to check blood cell counts, for example. Sometimes there's a couple of other things like eye examinations or blood pressure measurements that may also be necessary, or urine examinations that may be necessary depending on which medication you've been started on. And then serial MRIs are appropriate. So we usually do get annual MRI scans in most patients with MS. There are exceptions. If someone is fortunate to have very mild MS that is not active, then the intervals between MRI scans might be stretched out, for example. But as a general statement, certainly for the first few years, an annual MRI is usual. So to talk about DMTs for a moment, disease-modifying treatments or therapies. So studies have shown that treating early with DMTs is important. Studies show that delays the time to which someone will experience a second relapse if they have presented with their first. Studies also demonstrate that intervening early with medication can reduce the risk of going on to secondary progressive MS and can delay long-term disability changes and worsening of disability. And early treatment has also been shown to reduce the risk of death in the long term from MS. So I think any neurologist who you spoke to across the country would strongly advocate for the early introduction of a disease-modifying therapy in the vast majority of people who have a diagnosis of MS. So this is another laundry list here of a whole bunch of the disease-modifying therapies that we have available to us. It is not a comprehensive list. When I started my neurology residency over 25 years ago now, we had none of these drugs, not a single one. And the very first disease-modifying drug came out when I was in my second year of my neurology residency. Now we have something like 22 disease-modifying drugs approved for use here in Canada. This is a list kind of the most of the categories, at least, of drug that we have. And on this screen, they've kind of been roughly divided. The ones on the left-hand side are drugs that are approved for first-line use, meaning when someone has been newly diagnosed, and then the drugs on the right are medications by and large that we might then switch someone to if one of those first-line drugs isn't doing the trick. And this is just a kind of a look at, well, what are all these drugs doing? And all of these drugs are medications that act on the immune system. So multiple sclerosis is an autoimmune disease. It's a disease where one's own immune cells are in some way responsible for damage to the myelin and to the nervous system. And so all of the disease-modifying therapies in some fashion impact the immune system. So the early medications that came out 20 odd years ago, they all fall into this immunomodulating category. These are drugs that, in a broad sense, have impact on the way immune cells behave in a whole variety of ways. And these drugs are still tried and true. We still use them. Some of them are referred to as platform therapies, meaning they're kind of often a good place to start. They have the advantage of being very safe, and we have lots of experience with them. They've been around many, many years, so we really know their safety profile, and we know that it is safe for people to be on these drugs for long, extended periods of time. The con of these drugs, they're mostly injectable medications, which is not necessarily going to be everyone's favorite route of administration of a drug. And on the screen here, it says low efficacy. I think that's a little unfair. I think it would be more accurate to say lower efficacy. So they are not as potent as some of the other drugs to the right on the screen. But for many patients with MS, they will be enough to keep the disease rather under wraps and under control. So they are definitely an option. We still use them. Then we have the sort of middle category here, what we refer to as anti-cell trafficking agents. And these are all drugs that have actions on certain receptors on immune cells or tissues across which immune cells are going to travel. And essentially what they do is they have effects on where those immune cells can go. So some of these drugs really lock up those bad immune cells that are kind of gone haywire. They lock them up in prison in the lymphoid tissue, so they can't get out and cause mischief. These drugs, the pros are that they are highly effective. They're potent MS medications. They also have a very quick onset of action. Generally speaking, patients feel well on them and tolerate them well. The downsides of these drugs is, unfortunately, we have seen some serious, what's called opportunistic infections for some people on these medications. And this is a risk. It certainly by no means happens in everybody on these drugs. It happens in a small minority of patients on these drugs. But although it happens rarely, these kind of opportunistic infections can be serious. So when we use that term, opportunistic infections, what we mean is infections that take advantage of an individual who has a suppressed immune system. The other disadvantage, I suppose, when you look at this group of drugs as compared with the group on the far right, is this group of drugs, they don't get rid of the bad immune cells, they lock them up. So if we take people off these drugs, sometimes people can have what we refer to as rebound disease. And unfortunately also because they're somewhat newer, we don't yet have data on long-term efficacy. But I have to say with many of these drugs, we do now have many years of experience, but we don't know yet what does it mean to be on one of these drugs for a couple of decades. And then there's the cell depleting kinds of therapies. And these are very high efficacy drugs. They get rid of the bad cells, those immune cells that are really causing mischief. And so if we stop those medications, we don't experience or see this rebound effect. The downside is, again, opportunistic infections. In a couple of cases of these drugs, some people can also at a later date develop other autoimmune conditions. And as a general statement, some of these drugs are given as an infusion, for example, and so they're a little more cumbersome to use. So this slide is just a couple of words about sequencing, just so you're aware, because you may hear this term, you may hear your clinician talk about this term. This is something that's kind of top of mind for most of us physicians that work in the field of MS, is when we start somebody on a medication, we're not just thinking about that one drug. We're also kind of thinking ahead and saying, what happens if they don't do well on this drug? Where do we go next? And what will the repercussions of that be? So we do now have to start thinking a little bit of how will we sequence these different medications. As a general statement in this day and age, when somebody goes on a first-line medication, if they have side effects to that drug, then we may suggest a switch to a similar efficacy drug. So what we would refer to as a lateral switch. But if they are having problems on the medication because they're having breakthrough MS disease, then today, in this era, what we would do is escalate therapy to one of those drugs in a more potent category of medication, something that is more highly effective. So we escalate. There is these two approaches to treatment: escalation therapy versus what's called induction therapy. Induction therapy sort of says, let's not start with platform drugs first. Let's not start with, the low efficacy drugs. Let's go right to the big guns and whack that MS hard with something that's going to be highly effective and really suppress the disease. And there is some evidence to suggest that the induction approach might, in the long run, allow people to do better. However, it's not so simple and straightforward. When making decisions about treatment, we have to take into account lots of things about a patient, including their own wishes and their own risk tolerance and so forth. So as a general statement, I think we would say we tend to consider very high efficacy treatments from the get-go if people have some signs that suggest their disease is more likely to give them issues. This slide is just a way of kind of, bringing to everyone's attention that there are many, many factors that go into decision-making around which medication to start and which drug to switch to and when. Both patients and physicians will have many things on their mind in making those decisions. And really, those decisions have to be made together. So I don't think, you may get a recommendation from your doctor, but I don't think it's the doctor's role alone to make that decision for patients. I think patients have their own set of concerns. So things like, what does the drug cost? Things like, how risk tolerant is a patient? Things like life plans. Are they planning on becoming pregnant in the next couple of years if it's a young female patient? Preferences like oral medication versus injectable medication. These are all things that have to go into decision making, along with the things that will be in the back of the mind of your doctor, namely, how much disability does this patient have? How many relapses have they had? What does their MRI look like? So these are all things that factor into that decision. So it's never a one-size-fits-all situation. So again, these are some of the things that will be on the mind of your doctor, because these are things that can sometimes mean a worse prognosis. And when we have things present that suggest a worse prognosis, these are the occasions when we're a little more inclined to think more induction therapy than starting low and escalating. So things like the incomplete recovery from episodes of MS, a high relapse rate where people are having lots of relapses, short intervals between the relapses, and a really bad looking MRI that has lots of lesions. And this is just, again, a slide not meant to be scary so much as to be cautionary and to just bring home the point yet again of why we advocate for early treatment in MS. Often clinicians will use this score called an EDSS, the Expanded Disability Scale. And this is a status scale. This is a measure that physicians use to summarize, if you like, someone's level of difficulty that they're having in various different spheres of neurologic function. And so when one physician is talking to another physician, if they say someone's EDSS is 2, we all know what that means. That all gives us an idea of where that patient is at in terms of the degree to which their disease is affecting them. And so here's a patient who, at their diagnosis in the first year, they have been given a score of, an EDSS score of 2.5, which is really relatively mild. But it demonstrates that if that patient isn't treated, they are going to go on to an EDSS of 6.5 at year 15 and 7.5 at year 30. These are very high EDSS scores where people are no longer ambulating. They can't walk any longer. And so that's really serious, and we want to prevent that. So that's, again, what's in the back of the mind of your doctor when they are advocating for disease-modifying treatment. A couple of brief words about complementary and alternative therapies. There is no one specific MS diet that is recommended by physicians, and that's largely because, not to say there isn't some science to support certain aspects of certain diets, but we don't have scientific studies that say this specific diet is the way everyone should go, but there are certain general health things about diet that we recommend. So a healthy diet, a Mediterranean diet, lots of vegetables, lots of roughage, not too much meat, not too much fat. So these are things that are, general good health measures. Certain supplements and products have been touted as being recommended specifically in MS, and really we don't have good scientific support for many of those. There is support for saying vitamin D is important, and so we do routinely recommend vitamin D supplementation. But beyond that, there aren't firm recommendations based on science. So for example, cannabis. Lots of people with various kinds of pain syndromes use cannabis to treat their pain. Many people do report benefit from cannabis. Unfortunately, a lot of the use of cannabis for many pain syndromes is not done with a lot of science behind it. So it may be very useful, but we don't have lots of studies to support that. And there is some suggestion that, in fact, cannabis may be pro-inflammatory, which is not what we want in an inflammatory disease. So just a little bit of a note of caution there, that it's not meant to say don't use it, but it is meant to say that your doctor probably isn't going to be able to say, oh, yes, that's great, go ahead, because we just really, the jury's out. We don't have firm answers about that. And on the subject of vitamin D, we've known for a while vitamin D deficiency seemed to be related to the development of MS. Recommendations for how much vitamin D to supplement with have kind of bounced around a little bit all over the map. These are the recommendations, generally speaking, for the pediatric and adult general population. So anywhere from 400 to 1,000 international units is recommended. I do think in Ontario, you will see most neurologists, most MS specialists will suggest something around 4,000 international units. We don't want people taking like 10, 12,000 international units, because people can become vitamin D toxic. But we do know that 4,000 units seems to be safe, and that is routinely recommended. Another approach is to actually have one's vitamin D level checked and then supplement with higher doses until you get into the normal range, and then go back down to the daily recommended adult doses, for example. And here, I was talking about diet. Here are some other just general good recommendations. Physiotherapy can be helpful. Things like gait retraining and rehab programs can be helpful. I've already mentioned a balanced diet. We do know that things like smoking and obesity can impact disease. There are other comorbidities like diabetes and high lipid levels that can negatively impact disease as well. So managing those things and having a healthy diet, keeping one's weight down, and regular exercise are all really important. On the subject of exercise, I routinely recommend people with MS, my MS patients, exercise regularly. Exercise isn't going to hurt you. We don't advise people to exercise to the point of exhaustion. And it is important, not only with exercise, but with all activities, to kind of punctuate activity with periods of rest, so that you have a chance to recoup. But being active is an important and valuable thing, and I think helps people cope with their MS over their lifetime. And with that, I think I've covered everything that I was going to talk about. I hope I did not overstay my welcome.
Not at all, Dr. Schiffer. Thank you so much for being here, taking the time, and a really, really comprehensive and excellent presentation for all of us. So we so appreciate you being here. And to let everybody know, Dr. Schiffer will be staying around for the question period at the end of today's session. So please get those questions in, if you have any, into the chat box. So I'm going to move it along now to our next panelist today, and that is Lori Murphy. Lori has been with the MS Society for more than 30 years. She's been on the programs and services team for the past 25 years, and earlier this year, she took over the role of specialist for the education portfolio. So Lori is the lead for the Hear from the Experts series like we're seeing today. So today, Lori will be highlighting how the MS Society of Canada helps people affected by MS. So Lori, take it away.
All right. So we've launched a new strategic plan that really boldly maps out ways to accelerate our work towards a world free of MS. So it's a very exciting time. We want to put more effort to research, to find the cause and cure, and our staff works harder than ever despite facing a pandemic. So we're very excited, we're very motivated, and we will continue to not take our foot off the gas pedal as we move forward. So what are some of the things that the MS Society does to support people affected by MS? Well, our next two speakers will talk about the Knowledge Network and the Quality of Life program, but I'll focus on a few others. Education and awareness is very important, and it gives hope to people who are affected by MS. So we'll continue to do webinars such as the Hear from the Experts series. For the remainder of this year, we have two more coming up. November 10th is Dietary Choices in MS. And then we have on December the 8th, Lifestyle Choices in MS. On Thursdays, 3 to 4 p.m. Eastern, and more information is available on the landing site of our webinar. Under upcoming events, we'll always be posting when the next webinars are. But for next year, we are going to continue to offer at least monthly webinars for you to access under that umbrella of Hear from the Experts. Now, today is an MS 101 newly diagnosed session, and we're going to change things up a little bit for next year. We're going to try and offer monthly sessions so that we're better supporting newly diagnosed individuals on a regular basis. And it looks like it might be the third Tuesday of the month. So stay tuned and of information. MS 101 and education presentations to a variety of audiences across three. Whether it be staff at a long-term care facility, another health group, maybe a high school health class. Those presentations are helping to increase awareness about MS and what the MS Society of Canada does to support people with MS. We offer an MS e-newsletter across the country, depending on which region you're in. This is a newsletter that goes directly to your email inbox and not only shares some personal stories from people affected by MS, but it highlights our fundraising initiatives, our programs and services, maybe what we're doing with our government relations or advocacy programming. So it's a really great information sharing piece. And if you want to subscribe, you could try and self-identify on our website, or you could reach out to one of the Knowledge Network navigators, and they can help you get subscribed to the monthly e-news. We have a number of printable resources available on our website that you can access, specific maybe to symptoms and symptom management, such as fatigue, or talking to your family or children about a diagnosis of MS, even information for yourself when it comes to employment, and a little workbook or a little booklet for educating employers about what individuals with MS are going through. So there's many resources available to access to increase your knowledge, but also possibly share. Our website is in hopefully the last stages of redevelopment. So we're under construction. We want to make our website more user-friendly and offer some really new and exciting initiatives. So stay tuned. But yes, please check out our website at www.mssociety.ca. We have a number of different social media platforms that we're very active on. And that includes something new. We are on TikTok. I don't subscribe. But if you want more information about any of our social media offerings, you can email me at education@mssociety.ca, and I will try to support you to find the links you need. And I also want to celebrate Shared Voices newsletter. This is a newsletter that is created by people with MS for people with MS. And again, email me if you want a link to that regular newsletter so that you can see, again, more stories, celebrations of programs and activities across the country, and opportunities to further engage with the MS community. We offer two streams of peer support. The first being the one-to-one peer support program. So that's where individuals can complete an application that tells us a little bit about them, what type of MS they have. Maybe they're on a disease-modifying therapy and which one it is. Or maybe they're a caregiver, not a person with MS. Perhaps they have a burning question that they just need addressed in a one-call match, or they have topics that they want to chat with somebody else who has that MS lived experience through a number of different communication points, and we call those extended matches. And they could be anywhere from 3 to 6 months that we match individuals. Our volunteers are trained. And again, we're trying to find the most appropriate volunteer to connect with our applicant so that the information sharing is effective and meets both parties' needs. The peer support groups that we offer across the country, the majority are still virtual because of the pandemic. And we have a variety of audiences that are participating. Jesse mentioned that he's the facilitator for the newly diagnosed support group. We have a caregiver group. We have the MS Warriors group. These are open to everybody. If you'd like to explore the offerings we have for peer support groups, you can always reach out to the Knowledge Network or me, and we'll help you try and track that down and get you signed up for the group or groups that are most appropriate for you. Again, right now, the majority are virtual. They're over a number of different time zones. And there is some indication that some of the groups will be going back to in person. There's just not a lot of them right now. So you can always reach out and we'll share that information with you. But it's really important to note that volunteers are needed for both branches of our peer support program. And if you have questions, I have included the program specific emails for each of those in the slide. We have a number of virtual wellness programs that we're offering across the country. Time at Home is in partnership with Neuro Rehab out of Toronto. And it is a multiple times a week program that was designed by physical therapists and is for people who are mobile, more active. And people can register to participate, and they get a special link, and then they participate. Like Time, we've partnered with the University of Saskatchewan to offer a physiotherapist designed and led program. It's for people that maybe have a little less mobility. And again, you can register and be part of that wonderful program. Spirit Club is something that we just recently launched. It's a new offering with online gym and wellness programs and activities. So whether you want to register with us and participate in yoga or meditation or Zumba, maybe even a cooking class, we can help you get that free membership so that you can access some of these wonderful programs. Yoga for Everybody is a gentle yoga program that is really geared to anybody, including somebody who might be in a chair. And it's led by a certified instructor. It too needs registration, but it's offered on Fridays. And I think a lot of our constituents that have participated in the program have talked about the great benefit because this caring instructor that we have really takes the time to identify what an individual's limitations might be, and then to modify the exercises that ensures everybody can participate, even if there's some modification required. If you have any questions or want to explore this further, the email address is wellness@mssociety.ca. The MS Society prides itself in being an advocate for people with MS across the country and at all levels of government. We routinely lobby for change that might help shape or develop new policies and programs to really enhance the quality of life for people affected by MS. So whether you're signing on to help us with one of our letter writing or signing a petition, or even possibly helping somebody fill out a Canada Pension Plan benefits application, all of that is really helping to support individuals by MS and make a better future for everybody. And how can you get involved? Volunteering, I think, is one of the most important ways that individuals can get involved and make a difference. We have MS ambassadors that are volunteers who help us to offer programs and support or education in the community. So it's helping to extend the work of our staff. Sometimes we have governance type volunteers, and they're called MS community councils now. We love to have local community volunteers getting involved and helping us to continue our outreach. I just talked about government relations and social action. The peer support programs, again, need volunteers. sometimes we do need volunteer help with our wellness programs, whether it be the person that is helping to make sure that the video is playing at the correct time, or that they're helping to lead the discussion, the community chat after one of our wellness programs. There are a number of special events happening across the country, and we always need volunteers for that. And something new that we're working on, I talked about those MS 101 education presentations. We're going to be looking for individuals to help us deliver presentations across the country, so stay tuned for that. And lastly, fundraising and donations are very important. They're key to our work. So some of those special events would be our core events like walk and bike. We revised Readathon a couple of years ago, and it's doing very well. And check it out, because there's some real fun options for kids who can help to raise money for the MS Society, but they can have a fun game-like aspect. And we also have We Challenge MS. That's where we go ahead and encourage individuals to create their own fundraising initiative, again, where proceeds would come to the MS Society. But there's also many different ways to give your own donations or help curate donations for the MS Society, whether it be an in-memory gift, monthly giving, one-time donation, or helping us to set up sponsorships and maybe workplace giving, such as matching opportunities. So if you're raising funds for MS Bike, maybe your employer will match what you raise as well. So there's lots of opportunities to get involved and help make a difference. And you can always check out our website, or again, email me at education. I keep saying at first, education@mssociety.ca.
Fabulous. Lori, thank you so much for all your hard work over the years and for your presentation today. Now, our next panelist is another staffer with the MS Society, and it's Annette Mitchell. She's the specialist for the MS Quality of Life Equipment Program. She's been working with this grant program for more than 15 years, and it's a program that helps Canadians access funding to purchase and repair equipment. So welcome, Annette. Please go ahead.
Thanks, Gabrielle. So the Quality of Life Equipment Grant Program is set up to help people with MS who are in need of medical devices. So it is the program that allows us to provide financial assistance to those requiring support to purchase mobility equipment, safety devices, anything that pertains to a medical need in order to maintain personal independence and contribute to enhanced quality of life. So eligibility criteria for the program is a confirmation of diagnosis of MS or allied disease, which is generally provided by your healthcare provider. It's a doctor's note that just states you have MS. There is an application form that usually gets filled out by both yourself and a healthcare provider, which could be an occupational therapist, a physiotherapist, nurse practitioner, or a doctor, depending on what it is you're applying for. And then the program is open to all residents of Canada living with multiple sclerosis or an allied condition, except for residents of Quebec, in the sense that Quebec offers a really good program for funding for medical devices. So we look at other ways to support Quebec if the government in Quebec does not cover what it is they need. So it's never a no to anything. Conditions and criteria for the program. Please be aware that we don't provide after-the-fact funding. So we do ask, if you need help with financial assistance for medical devices, that you reach out to us, myself, or the MS navigators, to let us know what it is you're looking for before you purchase, because we want to make sure that we have enough funding in our budget, and that, again, it is something that's on our approved list. Applications may be submitted on a yearly basis. You can apply as many times as you need to throughout the year. However, there is a max of, currently it's $1,000 per year per person. And that could include anything from new equipment, used equipment, repairs for equipment. And that's a maximum per calendar year, so January to December, and then you can reapply again the next year. Applications are approved. Generally, once approved, it's about 3 months that you have in order to get an invoice into us. We can pay directly to the vendor, or we can reimburse clients depending on what the need is for the client. Eligible equipment that we offer everything from safety aids, bathroom safety aids, chairs, bath lifts, bath benches. We offer bracing supports, orthopedics, orthotics, walking aid systems. We offer computer adaptations, which can include home systems. If anybody's familiar with the Alexa home voice-activated programs, we can help fund some of those things. We offer equipment repairs, so if your medical equipment breaks down and you need help with supporting the costs to repair it, we can look at that. We offer help with hospital beds, lift systems, kitchen aids, mobility aids, your scooters, your walkers, your wheelchairs. We work with government programs, provincial programs, as well as other funders to help with those, as the cost for those could be quite high. We do offer things like commodes and bathroom safety aids, again, lift aids, vehicle modifications, which could include lifts, hand controls, ramps. So the list goes on. And if there's something that's not on this list that you're interested in, you can always reach out to myself or one of the navigators, and we can go through the full list with you. We also offer a cooling program. So the first part that I explained about was the equipment program, which is up to a max of $1,000 per year. Again, it can be anything from new or used equipment or repairs. But we also offer the cooling program. As you've heard from our panelists, we know that heat exacerbates MS. So we want to make sure that we offer our cooling program, which includes help towards either central air, portable or window unit air conditioners, or cooling fans. And that program is separate and above from the original 1,000, and you can apply to that program once every, central air would be once per lifetime, but air conditioners and fans would be once every 5 years. You can apply for help with funding those. Currently, that program runs from April 1st to September, but we are looking at extending that as well into next year to be open for the year. One of the criteria that we look at now as a national program is we look at the federal low income scale. This means that not only do you have to have a diagnosis of MS, but we do look at your financial situation, and we base that on the number of people in your household. So we look at the federal government's low income scale, which is the second column in, which is LICO. And then I've put in what the MS Society has put our low income scale at versus some of the others. So an example of that is a one-person household living in Canada, anywhere in Canada. The government has set the low income scale at 21,481. We at MS know that the disease can cause quite a bit when it comes to medical expenses and different things that you may need. So we have increased the low income scale to include 1.5. So we've times the low income scale by 1.5. So with MS, as long as your income is under $32,200 a year for a one-person household, you would be eligible for the max of up to $1,000 for the equipment grant and or the cooling program if needed. With Easter Seals, as an example, they look at the household income, assets, liabilities, and expenses, plus 2 years of income proof. And then March of Dimes is slightly over the government's low income scale, but again, does not match quite as much as what the MS Society will allow for. So we try to make sure that we include as many people as possible in order to make sure that everybody has the opportunity to apply for funding. And again, it's based on the number of people in your household, and moving forward from there. And that is across the country. It doesn't matter where you live in the country. We also know that there are extenuating circumstances, and sometimes your income may be higher, but due to other expenses throughout the year, due to experiences and hardships that you may be facing at this point in time, if an application has been denied, you do have the opportunity to appeal. The appeal would go to a committee of 6 people who either have MS, work with people with MS, are knowledgeable about MS, and or are peers. And they would make a decision based on all the criteria that's provided to us as to what the hardship may be, and a decision would be made that way. So you do have the opportunity to appeal if you are denied. If that happens, you would just work with myself to determine what your needs would be. So the best persons or the best people to reach out to when you are having just general questions about the Quality of Life Grant Program would be the MS Navigators, and you can reach them through the 1-844 number or the MS Navigators at MS Society. Or again, you can reach out to myself at equipment@mssociety.ca, and my phone number is also there, and I would be happy to help with any questions that may arise about the grant program. Thanks.
Excellent work, Annette. Thank you so much. Lots and lots of detail in there, and I really appreciate your time today. And Annette will be sticking around as well for our question period at the end of today's presentations. Now, all the information that you're getting today, that you're hearing today from the various people we have in today's panelists, I just wanted to put in a note that I've had the opportunity to volunteer with the MS Society for many, many years now, seen lots of changes and seen lots of opportunity. And I just want to reinforce this is a newly diagnosed session, that I really applaud everyone for being here today and learning as much as you can and gathering new information. And just a little word of caution about being overwhelmed. It's very easy to be overwhelmed when you're